Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 543 of our pharmacotherapy series, which majors in bipolar disorder. This part of the series involves patient TCR from parts 541 and 542 of this pharmacotherapy series. Valproic acid was chosen for the management of TCR's mania. How should valproic acid be initiated, and what baseline tests are necessary? How will TCR's response to therapy be monitored? The initial dose of valproic acid for TCR should be 250 mg 3 times per day. The dosage should then be increased by 250 to 500 mg every 2 to 3 days to obtain steady-state serum valproic acid levels between 50 and 125 micrograms per milliliter, or a maximum dosage of 60 mg per kilogram per day. An alternative strategy is to use an oral loading dose regimen of 20 to 30 mg per kilogram per day, given on a 3 times a day schedule during an acute episode of mania. This approach has been used during inpatient management and may result in a more rapid onset of effect. Valproic acid levels of 50 micrograms per milliliter are the minimum threshold, with higher concentrations offering greater benefit. In fact, those exceeding a serum concentration of 84 micrograms per milliliter by the 3rd day of treatment may have greater early symptom improvement. A pooled analysis demonstrated a linear relationship between serum concentration and efficacy, with the greatest improvement found in patients with valproic acid levels in excess of 94 micrograms per milliliter. Valproic acid levels greater than 125 micrograms per milliliter are more often associated with side effects and should be avoided. Before valproic acid is initiated, baseline laboratory tests, including a complete blood count, CBC, with differential and platelets, and liver function tests should be measured. TCR's baseline weight and neurologic status should be recorded. In premenopausal women who have not undergone surgical sterilization, a baseline pregnancy test is warranted since valproic acid is a known teratogen. Attention should be given to any medications that might be administered concurrently. Interactions with aspirin, lorazepam, phenytoin, phenobarbital, lamotrigine, rifampin, warfarin, felbamate, and carbamazepam are cited frequently. Also see valproic acid should decrease the severity and duration of TCR's current manic episode, decrease the frequency of subsequent episodes, and increase his time spent in a euthymic state. Once treatment has started, TCR should be monitored for response of his initial target symptoms, including grandiosity, decreased need for sleep, pressured speech, distractibility, and impulsivity. Initial symptom improvement with valproic acid can be expected in approximately 5 days. The next question reads, what are the potential side effects of valproic acid therapy? How should TCR be monitored for these possible effects? TCR should be monitored for potential dose-related adverse reactions of valproic acid, including various gastrointestinal complaints, such as nausea, diarrhea, dyspepsia, anorexia, sedation, ataxia, tremor, transaminase elevations, and thrombocytopenia. Reducing the dosage, changing to an extended-release preparation or administering an antacid or histamine H2 antagonist may mitigate gastrointestinal complaints. Central nervous system effects such as ataxia and sedation may respond to dosage reduction, although sedation may resolve with continued treatment. If a tremor is bothersome or interferes with the patient's functioning, a dosage reduction or change to the extended-release preparation may provide relief. Small elevations in transaminases are considered benign. However, valproic acid should be discontinued if elevations are more than 2 to 3 times the upper limit of normal. Weight gain occurs in up to 20% of patients receiving valproic acid. The increase in body weight is particularly distressing to some patients and may contribute to medication non-adherence. Weight gain has been associated with valproic acid at different concentrations, so a dosage reduction may not be helpful. In women, valproic acid has been associated with the development of polycystic ovary syndrome. Core features of polycystic ovary syndrome include oligomenorrhea and hyperandrogenism, which develop in about 10% of women with bipolar disease taking valproic acid. Alopecia occurs in 0.5% to 12% of patients and may improve with dose reduction. There are several reports of valproic acid-induced hyperammonemic encephalopathy in psychiatric patients. Patients presenting with coma or mental status changes should have serum ammonia and liver functions tests ordered. If valproic acid-induced hyperammonemic encephalopathy is suspected, then valproic acid should be discontinued. Other serious adverse events with valproic acid include fulminant hepatic failure, agranulocytosis, and pancreatitis. All of these adverse events require immediate discontinuation of therapy. In January 2008, the U.S. Food and Drug Administration issued a warning to healthcare professionals about the potential for an increased risk of suicidality associated with anti-epileptic drugs, abbreviated as AIDS, including valproic acid. For its analysis, FDA used data from 199 randomized clinical trials of 11 anti-epileptic drugs involving 43,892 study participants with either psychiatric or neurologic disorders. In the Warnings and Precautions section of anti-epileptic drug product labels, it is stated that the risk of suicidality for those treated with anti-epileptic drugs during clinical trials was approximately twice that of placebo treatment, that is 0.43% versus 0.24%, adjusted relative risk equal to 1.8, with a 95% confidence interval of 1.2 to 2.7, number needed to harm equal to 530. In these clinical trials, there were a total of 4 suicides in anti-epileptic drug-treated patients, and 0 suicides in placebo-treated patients. As a result, practitioners are advised to inform patients and caregivers to be vigilant about the emergence or worsening of signs and symptoms of depression or mood, behavior changes, especially if they involve thoughts or behaviors centered on self-harm when patients receive anti-epileptic drug treatment. Once valproic acid therapy is initiated, liver function tests, valproic acid serum levels, and CBCs with differential and platelets should be monitored at least monthly for the first 3 months and every 3 to 6 months thereafter. Body weight should also be determined at baseline and monitored monthly during therapy. TCR was titrated to a total daily valproic acid dosage of 2,500 mg per day and determined to have a steady-state plasma concentration of 95 micrograms per milliliter after 1 month of treatment. A routine CBC with differential and platelet count was ordered at this time, and the following data were reported. Red blood cells, 5.2 times 10 power 6 per microliter. A hemoglobin of 14.5 grams per deciliter. A hematocrit of 43%. A white blood cell count, 8.5 times 10 power 3 per microliter. Neutrophils 59%. Lymphocytes 27%. Monocytes 6%. Eosinophils 2%. Basophils 0.5%. Platelets 75 times 10 power 3 per microliter. How should TCR's valproic acid-induced thrombocytopenia be managed? Valproic acid-induced thrombocytopenia occurs in 18% of patients and is associated with female gender and higher valproic acid levels, that is greater than 100 micrograms per milliliter in women and greater than 130 micrograms per milliliter in men. Clinicians should educate patients to look for signs such as easy bruising or bleeding. In most patients, thrombocytopenia is asymptomatic and responds to a lowering of the valproic acid dosage. Complete discontinuation of the drug is usually unnecessary. TCR's dosage should be reduced, and his platelet count should be monitored closely. In addition, he should be observed for re-emerging symptoms of mania. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 544.